So good afternoon, everyone. I know that we'll be having some more people join us today, but hopefully you are trying to attend How to Get Involved. Oh, I have a typo already, in Pediatric Readiness Scholarship and Research. This is a webinar presented by the AAP Pediatric Readiness Subcommittee of the Section of Emergency Medicine. And today we are very fortunate to have an esteemed group of presenters. We have Dr. Craig Newgard from OHSU, Dr. Hillary Hewes from Utah, and Clay Mann and Michael Ely, also from Utah as well. So the objectives for today's session are that we hope that after attending this webinar, that you as a participant will be able to summarize research opportunities related to pediatric readiness, describe methods to access pediatric readiness data, and then commit to integrating pediatric readiness into your current and or future research and scholarship. So those are some high-level objectives we're aiming for, and we hope we can achieve those today. This session will be recorded, and please feel free to put any questions or comments you may have in the chat box. As we're starting here, I just want to provide an agenda. I, Mark Auerbach, am the chair of the AAP Pediatric Readiness Section of Emergency Medicine Subcommittee, and I'm here together with Teresa Walls, the incoming chair, who's currently the vice chair. We'll give a brief introduction to this quarterly webinar, then we'll move on to hear what NeedArc is and what it does from Dr. Hewes. We'll then hear from Dr. Newgard related to ED pediatric readiness and outcomes research together with Clay Mann, and really understanding how they went through a process of engaging in pediatric readiness research and scholarship. And over the last 15 minutes, hopefully a question and answer session with Drs. Hewes, Ely, Mann, and Newgard. So just a brief subcommittee update. I did want to congratulate the winner of our election, which closed last Friday. So Dr. Joyce Lee from Boston Children's will move into the vice chair, chair-elect position and serve in that role for the next 3 years. And Teresa Walls will move into the chair position starting October 1st. If you are interested in receiving emails and or getting more engaged in any of our working groups, please email Teresa as listed there. We do have quarterly webinars and quarterly administrative meetings, and our prior webinars are listed there and on the EIC website. So one of the topics that came up when we were disseminating information about this webinar and in our past webinars were the question of what is pediatric readiness. So I wanted to highlight and just start with some operational definitions before we get into the research and scholarship. And this might be very familiar to many of you that are in emergency medicine or pre-hospital care, but might be a new construct if you're in other fields. So the first effort was entitled the National Pediatric Readiness Project, and this related to emergency department readiness. And this was a multi-year improvement collaborative that aimed to ensure that optimal emergency care was available for all children whenever and wherever it was needed. It was a multi-stakeholder effort, and I'll come back to those stakeholders that were engaged. And really the aim was to ensure initially that all US EDs have the essential guidelines and resources to provide effective and appropriate pediatric care. And the process really followed this development of guidelines, development of a checklist, development of resources and a toolkit, and then a survey, which a lot of the scholarship we'll talk about today relates to that survey. The first survey was conducted in the Los Angeles area, then the first national survey in 2013 by NeedArc, and then in 2021, as of about a month ago, the most recent survey closed up. I did want to highlight that there's a pre-hospital pediatric readiness project that really follows some of the same elements and constructs that were mentioned there. And I know within our AAP working group, there's interest in office-based readiness, inpatient readiness. And I would say that all of these things are talking about emergency or acute care readiness at this point in time, not necessarily operational readiness for things like disasters. The pediatric readiness guidelines are sort of the dogma here that we're speaking to, and this is what leads to a pediatric readiness score and provides us the support for the research. So Marianne Gaucher-Hill and Kate Remick are on the bottom there. Marianne started this work back in 2003, and the key collaborators are listed there. So really some of the major players concurrently have published these guidelines on multiple occasions, most recently in 2018 for the hospital readiness, and I believe in 2019 for the pre-hospital readiness. And just to give you a broad framework, EDs across the country receive a request to complete a survey. This comes in a variety of forms. It's a mix of snail mail, email, marketing campaigns. And it's a 55-question online survey, and there's a weighted score that they receive across 6 domains that's weighted as listed there. So really, it's looking at the different domains of optimized systems of care. So it includes the people, so the providers, training and staffing, and quality improvement, patient safety, policies, procedures, equipment, medications, and administration and coordination. And all of those numbers add up to a total possible score of optimal readiness of 100%. This is what the survey looks like, sort of with some skip logic in there, and that reveals a pediatric readiness score. As I had mentioned, last month, we finished the National Pediatric Readiness Survey for 2020, which ended up occurring in 2021 because of COVID. And that data, will be having some numbers crunched and some access hopefully available in the upcoming year. This is a response rate map, and a total, it's really amazing, a total of 3,600 plus EDs nationally participated. So with that, I'm going to pass the baton over to Dr. Hilary Hewes to speak a little bit about the process of getting involved in pediatric readiness research and what the NeedArc organization is. Thank you, Hilary.
Great, thanks so much, Mark. All right, so my name is Hilary Hewes. I'm a pediatric emergency medicine physician at University of Utah Primary Children's Hospital in Utah, and I'm the principal investigator for NeedArc. Mike Ely's also here on the call, and he's our program director for NeedArc. We're going to talk a little bit today about what is NeedArc and how to access the NPRP data set. I can make this work. Let's see. There we go. So who and what is NeedArc? We are the National EMS for Children Data Analysis Resource Center. We've been funded since 1995 through a cooperative agreement with the Maternal and Child Health Bureau. And our basic mission is to act as a national resource center, helping state and territory EMSC managers and EMS offices develop capabilities to collect, analyze, and utilize EMS data. This is just a little bit more of a graphic of some of our main roles. So one of the main things we do is provide technical assistance to each state. Each state has an EMSC program and a manager in that state. And we have our staff providing technical assistance to them in terms of being able to help collect data and analyze data and utilize data and kind of fulfill the roles of the EMSC program. We also do a lot of customized software in order to complete the surveys and assessments we do, and then to be able to help with data visualization. So we do a lot of data collection. A lot of this is around the performance measures, which are a set of metrics in the EMSC program that help look at change and improvement over time on some basic metrics for pediatric care. We do a lot of data collection and then analysis of that data communication, which we use, for the most part, we use Tableau for data visualization to help people see the results of our data and understand why they're important. The NeedArc team and then other researchers, we all work together in publishing our data in peer-reviewed journals. And then we take what we've learned and do quality improvement projects, both on a state as well as regional, national level over time with that data. We talked a little bit about performance measures. These are a set of metrics that are used by the EMSC program to track progress over time. In regard to the performance measures, our job is to work with the EMSC program managers to collect data for 2 of the pre-hospital performance measures and 2 of the hospital-based performance measures. And then we analyze and help the program visualize that data, and then again, use that information to push forward quality improvement initiatives to raise the bar for pediatric care across the United States. So I'm just going to go through a quick overview about how the process we go through with our data collection. High quality data is one of our most important goals as a resource center. We closed the National Pediatric Readiness Assessment on August 31st, 2021. And we're now in the process of doing data cleaning and quality review. This is a pretty complicated process. We need to make sure there are no duplicate records or errors or hospitals that took the assessment for another hospital or missing information on required questions. We will then perform some initial statistics to get the data around our performance measures to the EMSC program and HRSA. And then we'll move on to analyzing the rest of the data that's present in the assessment. Our goal is to submit our manuscript describing the overall results of the assessment and change over time from the 2013 assessment by the end of the year if possible. And once the manuscript has been accepted for publication, we will then open up the data set to other research teams. We wanted to share some previous work that's been published using the NPRP data. Dr. Auerbach mentioned Dr. Gaucher-Hill, who's kind of the brainchild of this project and still one of the leaders of the assessment. And she published the overall results. She was the lead author on the overall result paper from 2013. We've had people like Kristen Ray look at different aspects of readiness, including geographic location of children to high pediatric readiness centers. We've had people look at very specific aspects of readiness, such as pediatric readiness in the Indian health and tribal emergency departments. And then Dr. Ames and her team was one of the first researchers to take the pediatric readiness data set and link it to patient level data and look at outcomes associated with pediatric readiness. And Dr. Mann and Dr. Newgard will be talking a little bit more about what they've done that's similar to that with data linkage. So let's move on to how you can access our data set if you're interested. On this page, you can see the actual website that will link you to our Pediatric Readiness Research Opportunities page that you can see there on the right. And this website will walk you through all steps of the process. You can see the picture up there, and there's some links on this website that'll take you through everything I'm about to talk about as we go on. Just as a reminder, though, we do have all research have a IRB in place before we can release any data to you. So if you are interested in doing this, you might want to start thinking about getting your IRB compiled as well. Very well. Oops, sorry, how do I get it to go back? Okay, there we go. Thanks. So just the overall process, we have an investigator who is interested in a project. They can access the data dictionary and identify the desired data elements they'd be looking into off of that website. And then they would submit a manuscript analysis request form, or a MARF, and there's a link to that document on the website as well. The MARF is reviewed by our NPRP research team and a statistician. And if it's approved, we would create a manuscript analysis plan, or a MAP, that's reviewed by the statistician and the investigator. And then once there's agreement on what exactly we're going to be looking at with the data analysis is initiated. Most of the time, we have the analysis done by our statistician, and the researcher doesn't actually obtain the physical data set. We do this to help bypass the need for a data use agreement, and also just to kind of help protect our data. However, in some cases, we have an encrypted password protected data set that can be sent to the investigator after a data use agreement is approved by the investigator's institution in the University of Utah. And in those cases, the investigator would conduct the analysis themselves. So this slide is really busy. This is the overall schematic of the process to request data, and we'll go through it piece by piece. But this is also a link on that website, and it really walks you through the process pretty in depth, and hopefully would be pretty self-explanatory. So as an investigator, you come up with a research idea like you would anytime. You would look through previously published papers, see what's already out there in the literature, think about what kind of overall statistics you're going to be using in your project, and then look through that data dictionary to develop a list of data elements you would want abstracted. Once you develop your research question, you would fill out your MARF, or your manuscript analysis request form, and then you submit that MARF to the EMSC DCC, which is our data coordinating center. It would undergo internal review by our research team and our statistician. We say it takes about 2 weeks. It probably depends on just how busy everyone is at that time, but about 2-week process. We would look that over and review your project. Most of the time projects are accepted. Sometimes we ask for a little bit of some revisions and resubmission, but once we've accepted your project, the statistician and the investigator would meet just to make sure they really understand how they want their tables formulated and the overall objectives. And then the statistician would complete a manuscript analysis plan. The investigator would approve that manuscript analysis plan, and then our statistician will do the analysis. And once that's done, we'll meet again as a team to discuss the results, formulate a discussion, and then finalize a timeline for manuscript submission. The nice part about this process is funding is not required for NPRP data requests or to receive the NPRP data if, oops, sorry, I don't know why that went forward. If your project is approved. But if you do plan to link the data to another database, unfortunately, you will need your own funded statistician in those cases. If you guys have any questions about this process, or you get on that website and this thing doesn't seem clear, you can reach out to me at any time. There's my personal email, and then there's the Peds Ready email, which goes to our general team, and we get back to you pretty quickly. We would love for people to use this data. That's the whole point of collecting it. So please, if you're interested, reach out to us. We can also help brainstorm ideas. We have several ideas for manuscripts in the works, and can add people onto teams. So please feel free to reach out at any time. Thanks so much, you guys.
So thank you so much. I did hear that there were about 5 individuals in another Zoom room, and I apologize. There was a standing webinar link from about a year ago. It looks like it did not get deleted, but hopefully those are all in this room now, and this was recorded. So thank you so much, Dr. Hewes, for sharing that process. And it's great to see that there's a very transparent process that can be navigated. And certainly I would suggest, engaging early and often, particularly if you are a young investigator and are interested in this work. And if you're an experienced investigator, probably early and often still a good idea as well. Speaking of mature projects, we're excited to hear today from Drs. Mann and Newgard. We did have the pleasure of hearing from many of the researchers that Dr. Hewes has mentioned in past webinars. So just to put a shout out for checking out the past webinars, and we'll send those, the link out with this webinar's recording. But we'll pass things over to Drs. Newgard and Mann to hear a little bit about their work now.
Okay. Hi, everyone. Thanks for joining. My name is Craig Newgard. I'm an emergency physician at Oregon Health and Science University, and I'm going to be presenting today with one of my colleagues, Clay Mann. Clay, do you want to introduce yourself?
Yeah, sure. Well, it's a pleasure to be here. I am with the University of Utah School of Medicine in the Department of Pediatrics here. I have the great pleasure of working with Craig for a number of years, and am excited to present today.
All right, so our first slide. So basically what we're gonna talk with you about are 2 projects that are ongoing, and they're funded by 2 separate grants. So I'm listing those here. One is a HRSA Targeted Issues grant, and the other is a NICHD R24, which is a research resource grant. And they've been supporting these projects that we will talk with you about. So we're going to start off by just giving a little bit of background on how we got involved in ED pediatric readiness. And I'll go first here. I think for a number of years, I've been very interested in emergency care systems and how those systems are applied and affect large populations, especially over hundreds of hospitals and hundreds of thousands of patients. And so when I started learning initially about pediatric readiness with a focus on ED care, that was quite interesting to me. And also I felt like this group was far advanced in the ability to quantify what readiness actually meant, and to develop a score for a single metric, being able to quantify a given ED's readiness. And at least at the time I started getting interested, there hadn't been any outcomes research yet done. And so that seemed a void that needed to be filled, and an opportunity to test the relationship between readiness and outcomes that, if that was shown, would be a very powerful statement about the utility and incentive of raising the level of readiness in EDs across the country. Clay?
Yeah, and my interest kind of piggybacks off of that. Most of my research deals with pre-hospital care, and of course, as was mentioned earlier by Mark, there's a part of the readiness process that includes pre-hospital. And really, I've always been incredibly impressed by the lack of research that kind of links together pre-hospital care, and then once a patient is provided to an ED, there seems to be a silo in that process. This research, I think, allows a bridge between that, and the readiness part of this is also incredibly intriguing, in that as Craig mentioned, there's really not a lot of outcomes research associated with this. So there is a possibility among this group to dynamically change what is collected or considered readiness based on what seems to be effective. So there's lots of great research, I think, that could really improve care.
So what I have up in front of you, this is our model of basically how these projects were designed. And the initial focus was on injured children. This is later broadened to include children with medical illnesses as well, but that's why we show injury event happening on the left side of the screen. So in general, just to kind of march our way through the model. So there's an event that affects a child. They are transported to an ED by a variety of means, and each of those EDs has its own level of pediatric readiness, which currently is quantified through the weighted pediatric readiness score. Those kids might be transferred to another hospital, and then basically we were most interested in looking at patient level data and tracking outcomes, health outcomes, specifically survival, but also metrics of quality of care, and then finally costs through a variety of existing data sources. And it was also clear that this sort of project could not just be done on one or two hospitals. This likely had to be done across hundreds or even thousands of hospitals and hundreds of thousands of children to be able to test that relationship. So that was sort of the vision that we implemented through these projects. So without getting into too much detail, I do want to show you what the aims are of these two grants. These were sort of our marching orders. So the R24 is really anchored on the 2013 NPRP national assessment, and aim 1 is really set up to try to describe and quantify emergency care over different cohorts of children over the US in terms of readiness, and looking at essentially where children receive care, what those unadjusted outcomes look like. Aim 2 was really one of the core aims of looking at what is the association between readiness and outcomes, quality, and costs after accounting for case mix and individual EDs. And then aim 3 is really looking at this concept of value of the balance between costs and outcomes and quality using a cost effectiveness model. And this uses an earlier set of data from 2012 through 2017. And then we partnered this with a subsequent grant through HRSA that really takes this concept the next step and looks at changes over time, and kind of brings these concepts up through 2021 and the current readiness assessment. And so these aims are similar, but looking at essentially changes over time with an eye towards outcome. That's aim 1. Aim 2 is looking at the idea of sort of testing the current national policy, which is raising the level of readiness across all EDs, and recognizing that that's probably not possible in every single emergency department across the country. So if that didn't get us as far as we wanted to go, what about the intentional selection of EDs within a feasible driving range? Would that ultimately result in more lives saved than current national policy? And then aim 3 was another look at cost. So that was kind of the framework that we started with. This is a busy slide. I won't go through every person here, but I put this up here just to show that we have a large team. We've tried to build a scientific community around these projects that's over 50 people all over North America. And the concept of the R24 is really anchored in a research resource. So we've tried to kind of build out a team that is able to take advantage of that resource. And you'll see that there's an eye towards young investigators in here to open up opportunities for upcoming early stage investigators. All right, I'll hand the reins over to Clay to talk about this slide here.
Yeah, great. So as you think about those research objectives that were associated with the 2 funded grants, really bringing together data sets is an incredibly complex process, right? So most health-related data sets within states sit within silos. So there needs to be some type of a linkage process that's done to bring those together. That's commonly referred to as probabilistic linkage, because often there's just not a lot of specific links that exist across data sets that allow that to happen. So if you can take a look at this, Craig's vision really to be able to look at this continuity of care. So you can look at clinical attributes, system attributes, all those things that could improve the care of children in regards to readiness. You really needed to bring these data sets together and link them. So states don't like to release their data without good, strong security measures. We had the good fortune of partnering with Craig, and we actually served as the data coordinating center here at the University of Utah. All the data came into us. We did the probabilistic linkage together. Here are these data sets. And then we sent a de-identified data set to Craig and his statistical team to be able to evaluate the hypotheses that were associated with those objectives that you saw. So there was great value here, I think, also for states to release their data, because they could see that the data went to a different group who did the analysis and did all the de-identification before the data went to those who would be doing the analysis. There were also other advantages. I'm the principal investigator for the NEMSIS data set. So that already existed here at the U. I work with Hillary very closely. So the National Pediatric Readiness Survey data was already here. And so that process that Hillary talked about never really releasing the data set to outside our reviewers, and they hold back some elements, we were able to take advantage of those additional elements and that additional data because the data stayed here. The data stayed with us. We also had a relationship with the American College of Surgeons, and so we could use the trauma data that they collect and the characteristics of the hospitals caring for those patients all together. The linkage data set that had to come together, the green boxes, that's data from 12 states. Their emergency department data, their inpatient data, and then we had vital records data from 8 of those 12 states. Linking those together is an incredibly complex process that we have completed. And then of course we had the NEMSIS data associated with their care prior to arriving at the hospital. That's all brought together and shipped off to Craig. Craig, you want to describe a little bit what happens once you get it at OHSU?
Yeah, thanks, Clay. And I think a key element of why this project was complicated is that we wanted to get PHI for individual patients from at the state level. And so that's basically asking for identifiable records for millions of children. And that makes a lot of states nervous. So we had to really set up a very sound plan for how those data sets were going to be handled, keeping them secure, making sure that confidentiality was not breached. And we needed PHI in order to link in, say, vital stats death records, and to be able to track children out to 1 year. We also needed the PHI to be able to link in the readiness survey, and to be able to self-match these data sets down from the event level to patient level. So there's a lot of different steps that required that we needed PHI, and that was guided by multiple data use agreements that we'll talk about later. But this sort of process of why does the data have to go back and forth between two centers? This looks pretty complicated. It is complicated, and we're basically trying to navigate through kind of a legal and confidentiality framework that each of these states has to abide by. So, so what we're going to do, I'm going to see if I can move this forward. There we go. So I'm going to talk with you about each of these 3 data sets, just so you have kind of an understanding of how they're built. I'm going to try to make sure we don't use up all our time doing this, as you're going to see there's a lot of detail here. And basically what I'm trying to do is just give you a sense for how we built these data sets, where they came from, and what the sort of behind the scenes effort looked like in creating them. So there were 3 cohorts that we were looking to get at patient level data and largely be nationally representative and be able to link each of those to the 2 national pediatric readiness assessments. So the first one, this is the National Trauma Data Bank cohort. And if you're familiar with the NTDB data, there's basically a compilation of trauma registry data from trauma centers all over the country. So it represents 50 states. And this is the biggest combination of trauma data in the world. So there's a very rich amount of information here. Functions on a standardized basis for the inclusion criteria, how the variables are created, et cetera. And we basically took this data set and working with the American College of Surgeons, again, with PHI, so that we could link in vital stats records. And there were multiple data processing steps. Some of the core ones is to, we required that we had the initial ED records. We knew where that child began, what things look like at the start, and that there was also a pediatric readiness data record that we could match into the initial ED. So that was mandatory. We tried to track all transfers as best as we could, ideally with a probabilistically linked record from the second hospital. And this basically generated a cohort of just over 372,000 children who were admitted to trauma centers across the US. And I'll show you some of the results subsequently. This is a slide with a lot of numbers, but this is our 12-state cohort. It gives you an idea of the volume and magnitude of records that we're looking at. So again, these 12 states are kind of scattered over a variety of portions of the US. And in putting, these are close to final, but basically in putting these records together, these are all children presenting to any ED in these 12 states over a 6-year period. So from 2012 through 2017, 22.8 million children are represented here. And this is after accounting for matched pediatric readiness records from the initial ED. We separated this out into an injury cohort and a medical cohort. And then I mentioned briefly earlier that we, in states that don't already create a patient level data set, so what's most common is they have a event level data set. So every ED visit or every inpatient record is tracked as an event level. What we really wanted was to get that down to the patient level. So we self-matched those records, and then that gave us an opportunity to track children over time and what repeat visits and repeat hospitalizations look like. So those are represented in the far column here. And then finally, the EMS cohort. So this comes from the Nemesis Technical Assistance Center, the one that Clay directs. And again, it's a pretty busy slide, but just gives you an indication that there's a lot of work that goes into creating this cohort. So this is, we try to get down to the patient level, and these are individual children that are transported by ambulance to an ED where we had a matched pediatric readiness record. So we could see where these children went through a lens of readiness. And we also wanted to match in a variety of other data sources, census data, American Hospital Association data, NTDB data. And then finally, we have a colleague that did a geospatial analysis on these records, which is almost 800,000 children to look at geospatially, not only where they went, but from the centroid of the incident zip code, what were the other options? Where else could they have gone, say, within a 30-minute driving radius? So these are data that we're currently analyzing. I'm hand it over to Clay.
Yeah, and just quickly, we talked much about this. This was really, as Eric mentioned, this was kind of a political and legal, just constant morass to kind of make this work. And Craig has a great person working on his team from OHSU that really kind of balances the institutional review boards from 12 states, and of course from OHSU and from the University of Utah. It's a constant battle, constant renewals, and so this truly has been a process of the heart to try to make this work. And what, Craig, we're probably probably 2 years of pretty consistent work to kind of bring these data sets together and get them ready for analysis.
That's right. Yeah, and you can see here, we had talked earlier about these data use agreements. These are legal documents between the owners of the data and us, and this is how we were able to get PHI. So these are not public use data sets, at least the ones that we were after, as we wanted to be able to link in these different records at the ED level, at the hospital level, and at the patient level. And so that added a very thick layer of complexity to this project. And currently how this works is that we don't have the ability to send data to outside investigators. That was the initial vision, is that we would create a research resource and be able to send these data out for an army of people to analyze, but our current data use agreements don't allow that. So all the analyses must be done within these two centers, so OHSU and University of Utah, and is further restricted to named members of the project team listed on those DUAs. So basically, it's our statistical team needs to do the analysis, and we're going to go through kind of the process for doing so and getting involved in writing groups in the subsequent slide. So we have one publication so far, several more in the works, but this one came out in June. So I'm going to talk with you a little bit about this. So this is kind of building on Stephanie Ames and colleagues, their work in looking at the association between readiness and outcomes. So we did this in the context of U.S. trauma centers using the National Trauma Data Bank. This was, as I mentioned before, just over 372,000 children over a 6-year period. You can see some of the outcomes here. We wanted to look at not only in-hospital mortality, but also in-hospital complications as a measure of quality. And then what was interesting was that there's very, very little overlap between these two groups. So these really do represent largely kind of different measures of patient-related outcomes. So children had to survive long enough to develop a complication. So sort of answering a slightly different question. And then we looked at a variety of subgroups based on severity of injury, just to sort of get a sense of whether readiness truly applied to all injured children who had to be admitted, or whether it was really only measurable within certain kind of high-risk subgroups. So this is one slide that just this builds on Kate Remick's work of looking at kind of what is the spectrum and overall distribution of readiness over U.S. trauma centers. We can see each of the bars in the histogram represents a number, or the number of trauma centers within certain bins of readiness. And the blue line represents ED volume, and the median ED pediatric volume within each of those bins. So basically, as volume goes up, roughly readiness goes up as well, but there is definitely variability here. And this is our kind of key outcome slide here. So if I draw your attention to the red box on top and focusing on the panel on the left, these are the results of a multivariable risk adjustment model that basically takes into account the case mix by ED and is looking at each of ED's different quartiles of readiness from highest to lowest. The lowest was the reference group. So you can see here that basically when measuring in-hospital mortality, that children that were initially cared for in a trauma center with a high readiness ED, high readiness meaning in the upper quartile of readiness, that these had a independent association of lower in-hospital mortality if you were initially treated there. And what's interesting is that this persists even after looking at kids that were transferred over different age groups by injury severity, different measures of high risk. If we then kind of look at the right-hand part of this box, This is the combined outcome of in-hospital mortality or complications. And there really was not a consistent relationship between readiness and outcome when looking at an outcome that included in-hospital complications. So it really started to tell the story of, at least temporally, outcomes that seem to occur closer to ED care, that there's a more direct relationship there, and outcomes that happen later in a hospital course might be less impacted by readiness. Some of the other papers that we have, this one's under review right now. This is looking at the subgroup within those trauma data, where we'll be able to link vital stats records, so basically track survival out to 12 months. So there's 88,000 children in that group. The graph on the bottom is basically a plot of among children who die, when they die. And you can see that in general, among children who do die after trauma, death happens early. So again, this fits in with proximate outcomes to ED care are probably most affected by ED readiness. And then I'll let Clay describe this one.
Yeah, this is another study that we're currently working on. This is the one using NEMSIS data, almost 800,000 kids transported via ambulance using the NEMSIS data. This is a great paper. You can see here geographically across the country, just the number of kids that are transported to hospitals with different readiness quartiles. And for each of those patients, there on the right, you can see that smaller kind of figure. That's my hometown, that's Salt Lake City. And we're able to do this for each kid. So there it's kind of hard to see, but if a kid, this is a single patient with either an injury or illness in West Valley City and was transported with that blue line horizontally to the left to a little yellow dot that they were transported to a hospital in the second quartile of readiness. But the great work that was done could have gone by the hospital's level of readiness, right? So did that patient travel the shortest distance to the highest level of care? And so this type of analysis is underway right now. It's exciting.
Yeah, thanks, Clay. And then something that I didn't mention in the paper that came out in JAMA Pediatrics earlier this year, but I'll mention briefly here, is that we're also really interested in these just very practical numbers, this concept of how many additional lives would be saved if all those children were cared for in a high readiness ED, either by raising the level of readiness among all those trauma center EDs, or by very, very intentionally selecting an ED for transport, say by EMS, that had high readiness. And using our model, we were able to back out those numbers that at least over those 800 some odd trauma centers over that 6-year period, there were over 700 children who, based on those models, would have survived if they had been taken to a high readiness ED. So those were kids that were taken to EDs in the lower quartiles of readiness. And so that ends up basically giving us a quantifiable estimate for how does this translate into preventable mortality. And so translating that into EMS work, we get an idea of if we change EMS transport patterns, how might that affect the number of lives saved in children across the US? So, and we just have 2 more slides here. So I'm sure some folks are asking the question of how can you get involved? I mentioned earlier that our data use agreements prevent us from sending data out, and at least until we kind of march our way through the aims that I showed you earlier, we don't have the bandwidth quite yet of undertaking secondary data analyses, but we do have a number of writing groups. The top block, the current writing groups, are a variety of different kind of questions related to readiness that build on or directly answer those aims. These ones are already formed. Those are anchored with the 2013 assessment. We have 4 more writing groups that will be coming up. Once we get the state data finalized, those are looking at in-hospital outcomes, long-term outcomes, costs, and then the cost effectiveness. So those are not yet formed, but will be getting formulated. And then finally, with the 2021 readiness assessment done now, pretty soon we're going to be training our attention on more recent data and the 2021 readiness data. It takes 1 to 2 years after a calendar year to get the patient level data. So, and even after that, there is a significant amount of work in building those data sets. So it's going to take some time to kind of get the patient level data matched and ready to analyze for the 2021 assessment. But those will offer some additional opportunities for writing groups. And the way that we've run this so far is basically people that are interested, if you email Clay or I to give us an idea of why you're interested, which of these topics you're interested in, and we'll keep a running list of people that we could offer the opportunity for co-authorship on these writing groups as they open up, with preference for early stage investigators. That's it. Thanks for your attention.
Thank you so much, Craig and Clay, for that review. I think that I wanted to highlight for those of you that joined later onto the call that this was going with our pediatrics here, this was a adult maturity project. So this is a project that is quite intensive, quite mature, also quite compelling in terms of that linkage to patient outcomes. But at the beginning, if you were not on, or if you were on, just to reiterate that Hillary mentioned some opportunities using the MARF and other processes to engage in projects that perhaps are, a bit more proximal to, entry for you, that, do not have the sophistication of overlaying data sets, but potentially would allow you to leverage pediatric readiness in your work in other ways. So with that, I would be very enthusiastic to, open the floor up to questions. We have about 12 minutes left here. So whether it's questions on the project that Clay and Craig presented, or questions about engaging in access to pediatric readiness data through NeedArc, please either put them in the chat box or post them, or speak aloud or unmute yourself. So we have Mike Ely from NeedArc and Hillary from NeedArc, Clay from NEMSIS and the project that he discussed, and Craig from that project. Yeah, please share any questions that you may have.
Mark, can you see the chat? It's Teresa. There were a couple questions as the presentation was going on that we could read out, or?
Yeah, go ahead. If you can share those, that would be great.
Oh, one person asked, I guess, is it likely that more states will be part of NEMSIS or the SED database sets in the future? I don't know if our speakers have any predictions on that. I think they're referring to the 12 states, states that have that data that is able to be linked.
Yeah, I can take a stab at that one. I think, Clay knows the NEMSIS data better than anyone. We selected those states based on states that had at least an estimated 90% capture rate of their EMS data at the state level. And then on the ED data, the way those 12 states were selected, of course, was not random. We wanted geographic representation, but beyond that, we needed states that were willing to give us PHI for millions of children, which of course limited the number of states that was willing to do that. And we started with a longer list. We actually started with 24 states and reached out to most of them, and then that list got whittled down to 12. And even within those 12, there were 4 that we have not been able to get PHI at the individual patient level. So although it's possible that there's more states that will open up, it's not as easy as just simply adding states on, because it has to do with their willingness to share confidential data.
Great, thanks. Yeah, that makes sense. It's a lot of information. And And one other question was, I'm not sure, we probably don't know this for the 2021 survey obviously yet, but how many non-children's or non-university based hospitals have achieved sort of the maximum level of pediatric readiness? I don't know if you have a sense from your data in terms of the trauma centers, like how realistic is it for them to, the non-academic places, to achieve this highest level?
I can tell you, I think Hillary might have a better sense of this over all types of hospitals or EDs, but within the NTDB data, so for US trauma centers that send data to NTDB, in that highest quartile, there were 13% of those EDs that were part of level 3 and level 4 trauma centers. So that gives us some idea that it's not a huge number, but they still can reach a high level of readiness, and that at least a chunk of kind of lower level trauma centers have gotten into that high level of readiness.
Yeah, I was just trying to look back through the manuscript from 2013. We definitely do not have the data yet for 2021. The biggest factor in terms of reaching a higher level of readiness has always, we've thought, been the presence of having a pediatric emergency care coordinator, both a nurse and a physician. Presence really helps boost your score, kind of independent of geographic region. So that's one thing we always try to really encourage folks to do. But looking at the kind of hospital volume, those lower, medium, and medium to high centers, there's really very few that are reaching that kind of above 90 on the weighted pediatric readiness score. Mike, I don't know if you know the exact number, but I really do think it is volume dependent. So obviously you're going to find most of the higher pediatric readiness centers in the urban areas with high pediatric volumes.
Yeah, that's definitely true. It's readiness is definitely correlated with volume, with patient volume. So and having the PEC positions in place will, of course, help a lot with the readiness score. But the idea being that having a person at the hospital level, a physician and or nurse, a coordinator or champion, who doesn't have to be, that's not their only role, of course. In most cases, it's going to be a role assigned to an individual who's already at the hospital and got other responsibilities, but a person who's basically dedicated to making sure that the needs are met of the pediatric population for in terms of policies, procedures, equipment, all that sort of thing is probably the single most important thing in terms of readiness for hospitals and pre-hospital as well.
So a couple comments from the chat box. I think that today we talked about more database studies, looking retrospectively at patients, and there is a study that is being that is put out there as a TI grant that Kate Remick is leading, looking at pediatric readiness improvement and understanding at a site how improving pediatric impacts pediatric readiness improves outcomes. And there's been a number of prospective studies looking at different methodologies to improve pediatric readiness. And if you are not involved at your state EMSC level, I would just encourage you to consider reaching out to the EMSC program in your state, something called the State Partnership Program, to engage with them on efforts to improve pediatric readiness, because pediatricians, as many of you are on the line today, are really a must-needed part of that equation. So please consider doing that. And, in terms of the volume to outcome ratio, I think that, there is this, challenge that you are likely to be more focused on pediatrics if you see more pediatric patients. But I think from the data that we've seen today, there's many patients presenting to those lowest volume hospitals. So raising that floor of readiness in the lowest volume hospitals is something that I think is a critically important part of our work. I'd be interested to hear from Craig and Clay in terms of, the options out there, I guess, looking at this data. And I know you probably don't have a cut and dry answer. If we were to optimize transfers, in your geospatial analysis, what percentage of kids would that take care of? Roughly, is it 50%? Is it 90%? Versus if, and when we optimize transfers, how many of those kids would still be presenting to a lower volume, low pediatric readiness hospital?
Yeah, thanks, Mark. We do have some of those numbers. So we're still analyzing the NEMSIS data. I think in using the terminology, so transfers, I think some people think of an EMS transfer, like taking them from the scene of the hospital. Other people use transfer for an inter-hospital transfer. So just to clarify, we've been very focused on the initial ED and the readiness of the initial ED. And whether that child is subsequently transferred or not, that link still holds. So basically, if that child presents to a small volume ED and is subsequently transferred to a large volume big trauma center, it really is the ED readiness of the initial ED is independently associated with outcome, even if we stratify and look at just transfers. But this issue of what EMS transport patterns look like. So at least currently across these 28 states, there's about 35% of those transports. We've just looked at injured kids so far. About 35% are taken to EDs in the highest quartile of readiness. And then that kind of begs the next question of how many could have been transported. So there's another about 25%. So if we take into account current transports to high readiness and who could have gone to a high readiness ED based on a 30-minute transport time that takes into account traffic patterns, there's about 60% of kids who could be transported to a high readiness ED, but only about half of those are.
That's really helpful, Craig. And I think I want to highlight that many children are not coming via ambulance and might be coming with their parents. A question came up from Dimple Kona that, comparing a high ready non-children's hospital, non-university hospital to a high ready children's university hospital. Can you all comment on that? Are those similar? Are they different? That certainly the brand of a children's hospital might make a consumer think it's quite different than a community hospital, even if it is equivalently ready.
Yeah, it's a really good question. And I think we'll probably need to turn to the state data to try to answer that. We did in the trauma paper, we did try to look at that by including multiple other hospital level characteristics in the model to see if that changed the association between readiness and outcome. So we added trauma center type, so adult, pediatric, mixed, trauma center level. So, very commonly used measures of what type of hospital is that and how resourced are they. We also added ED volume and trauma volume, so the number of trauma admissions, pediatric trauma admissions per year. And the bottom line there was that after adding every single one of those, in general, the relationship between readiness and survival persisted. So even after taking into account a bunch of other hospital characteristics, many of which have been independently linked to survival, that relationship still persisted.
Thank you so much. So thank you everyone on the panel for your time, and thank you to our audience for your time. I did put a link to the current EMSC funded programs. Within that, you can find your state partnership program. There were some questions in the chat about a state level analysis, and that would actually not be through NeedArc. It would be through your EMSC state partnership program. A national analysis would be through NeedArc and data linkage type efforts. Is that correct, Hillary? I just want to confirm that that was my understanding.
Yeah, I just tried to clarify that. So if you're looking just to get data on your state, once we have it cleaned and ready, we will be giving individual state data out to the managers, and you can reach out to your state manager to work with them and improve pediatric readiness throughout your state. And if you want anything beyond just individual state data, that would need to go through the MARF process.
Well, thank you to Clay, Craig, Hillary, and Michael for sharing your work. It's quite exciting to see this linkage of pediatric readiness and patient outcomes. And hopefully many of you on the call today can get engaged in efforts to either help to understand that linkage and or efforts to help intervene and improve pediatric readiness. So thank you for your time. We'll post this on the website, and hopefully this may springboard some future collaborations, and really appreciate everyone's hour today. I know everyone's quite busy. Thank you again.
Thanks, everyone.
Thanks, everyone.